So why do we need to discuss hepatitis B and C in children? And it was a challenge putting both Hep B and C in the same presentation. It's a huge subject. And we have special meetings for adults for Hep B and special meetings for Hep C. But I'll try to highlight the most important issues. From a clinical perspective, infection is mostly asymptomatic and not considered by pediatricians as an infection of children, so that's why it is important. Children do not undergo regular checkups or biochemical testing or donate blood, and many of them have normal ALTs even if they are infected. The risk factors are not sought and extrahepatic manifestations are quite rare, while progression of liver disease varies according to addition or association with comorbidities or not, or special subpopulation groups. But also from the public health perspective, this is really important because children are a reservoir of infection. They transmit infection, and this is really important. Now we have cure for hepatitis C, so we can use cure as prevention. And we do have drugs that suppress the viral replication for hepatitis B. And we are not considering children who are marginalized, populations that are immigrants, displaced, refugees. We have 10 million displaced or refugee children or those coming from conflict zones. This is a huge population. We don't have screening policies. They are not within the strategies of countries. We don't have screening policies, particularly for children or even for women in childbearing age. And of course, WHO cannot eliminate or achieve their targets for elimination unless hepatitis is considered in children. And this is just a thought that 1/3 of the global population are below the age of 15, and there are 1.2 billion adolescents living between ages 10 and 19 globally. And this is a considerable population, and most of those, or in some areas, they are a high-risk population group. So what about the global burden of hepatitis C? This is a study that we've done with Homi Razavi and his team, and we're currently writing the manuscript. We had a previous study only for 24 countries, and at that time we thought that we had a global viremia from modeling and extrapolation of around 6 million children. However, with inclusion of more countries, 102 countries now included in this analysis, we have around 4 million viremic children. And if we look at the age, we will find that it increases with age, with the maximum between ages 15 and 17. 21 countries are responsible for 80% of the global burden of hepatitis C in children, mostly Pakistan, among other countries, and Egypt comes fourth. What about the global status for hepatitis B? This is also a big population that should be considered. There are around 48 million children who are HBs antigen positive, according to WHO, below the age of 18 years. Vaccination, 84% of the countries have the 3-dose coverage, while only 39% give the birth dose of the vaccine. S antigen dropped from the pre-vaccination era to now, from 4.7% to 1.3%, so vaccination has been quite effective. But it's not only about children, but it's about women who transmit the infection of hepatitis C as well. Although the infection transmission risk is 5 to 7%, however, it's a big burden. This is another study with Homi Razavi looking at the burden of disease in women in childbearing age between ages 15 and 44. And here we have almost 13 million women globally who are viremic for Hep C. So this is a group that should be considered, that should be prioritized, and there are no guiding policies for prevention of transmission of hepatitis in women of childbearing age. So this is, I think this is very important, and we need to integrate this into our guidelines, and we need to prioritize also this population group. Also, 80%, 28 countries are responsible for 80% of the infection between China, Pakistan, Egypt, as well as India. But this is also our latest study. This is a global analysis and modeling study with Homi and his team as well. And the manuscript is being prepared now. And this looks at the S antigen prevalence in all countries with modeling and extrapolation for 5-year-olds, because that reflects directly on the vaccination policies in the last 20 years. And as we can see, India and in Africa as well, we have a high burden, particularly in Nigeria. It has the highest burden within the African region. But also it's important to look at the prophylaxis policies. The prophylaxis policies are lowest in the areas with the highest prevalence, with the highest burden. That's the Afro region in blue, while it is much higher in the Western Pacific region in orange. While the perinatal prophylaxis and antiviral therapy is only almost available in the PAHO region in North America. That's in the violet color. Just forgetting to mention that the Delta virus, we have no data on Delta in children. Data are lacking. So the situation of Delta is very questionable. We do not know how many children are infected with Hep B have Delta virus. So who are the children at risk of hepatitis B and C in both high and low middle income countries? Children in low middle income countries who undergo recurrent blood transfusions, who are exposed to multiple invasive procedures, including circumcision and tattooing. Children born to HCV-infected mothers have a risk of 5 to 7% of transmission, but those born to E-antigen positive Hep B mothers have a risk of up to 90% of transmission according to level of viremia. While children with an infected household member are exposed as well, particularly in low middle income countries sharing personal care items, and we should not forget adolescents with high risk behavior. So what about the prevalence in my country? The latest demographic health survey looks at 0.2 to 0.5% in children ages 0 to 15 and around 0.8% in children 15 to 19 years old. While if we look at the demography in Egypt, 50% of the population are below the age of 25 and 1/3 of the population are below the age of 15. So we're looking at around 150,000 children below the age of 18 infected with hepatitis C or viremic for hepatitis C who require treatment, but we have added to the pool another 10,000 every year with mother-to-child transmission, as the viremia in our population is around 7%. We have a population of almost 100 million now. So what about the United States? There were alarming reports in recent years. Of course, you've heard that in the last few days about the heroin epidemic. And I'm going to focus on two groups, the women who are in the childbearing age and their children. And there was, on a nationwide basis, an increase of 22% in women of childbearing age in the US between 2011 and 2014, according to CDC, and 14% increase in the children below the age of 2 years. That's very important. And in another paper just recently published 2 months ago, looking at substance abuse in children, and from 2006 to 2012, they looked at children who were hospitalized with a mean age of 17. Adolescents are considered adolescents up to the age of 19, so those are still children. So HCV among those represented 68% of total HCV diagnoses, with 54% of increase, and the burden was highest in whites, those coming from low-income quartiles and northeast and southern regions of the US. And the prevalence of substance use among children with HCV increased from 25% in 2006 to 41% in 2012. That's a huge increase. So what about the natural history of Hep C in children? Infections acquired during infancy are more likely to spontaneously resolve, and fibrosis of liver tends to increase with age, but the children who acquire Hep C very early have a likelihood of 26-fold of increased risk of liver-related deaths. However, 50% of those acquiring the infection early might clear the infection before the age of 6. There are lots of comorbidities that increase the risk of progression of liver disease, including HIV co-infection, among other comorbidities, including siderosis, steatosis, and cancer chemotherapy, among others. And this is some of our data looking at fibrosis and the risk of fibrosis in children receiving chemotherapy who experience multiple reactivations of hepatitis C and multiple flares, and it is directly significantly correlating with the number of flares and reactivations during chemo. I would like to remind you that most of the children with cancer are diagnosed with leukemia, and the duration of chemotherapy is up to 4 years. While on the other side, we found that also the lipid profile is disturbed and hepatic steatosis is common, and that's an independent risk factor as well for progression of liver disease and fibrosis, and in the old days, it had a worse response to pegylated interferon and ribavirin. And there are lots of other comorbidities, and liver biopsies help in children with comorbidities. We still use liver biopsies at times when we have issues with a Hep C patient who's infected and had a comorbid condition. We still need liver biopsies. We can see on the left side, this is an HCV-infected female. She had leukemia, but she also had siderosis because of disturbed metabolism of the iron during chemotherapy. On the right side, we had another one who had a bone marrow transplant for thalassemia and was HCV infected, and we could not differentiate whether he had a reactivation of Hep C or this was a graft versus host disease. And he had a special stain with cytokeratin 7, and it could show clearly this was a chronic graft versus host. While also steatosis and glycogenosis are common in diabetic patients with hepatitis C, and we do see children who are infected with hepatitis C who have also diabetes as a comorbidity. So shifting to the natural history of hepatitis B, of course we know that infected neonates have a higher risk of chronicity than adults who get infected with hepatitis B. So although they're usually asymptomatic, fulminant hepatitis is very rare. We sometimes have extrahepatic manifestations like Gianotti Crossi syndrome. This is a papillary acrodermatitis. It's seen in young children. It might continue for weeks with mild fever, lymphadenopathy. It's usually anicteric, and older children, adolescents, usually do not experience except very mild fatigue and constitutional symptoms, and very rarely with some flares and even fulminant hepatitis. Also, among other extrahepatic manifestations, we have membranous glomerulonephritis, and sometimes we have, of course, a rapid progression of liver disease in children, and I've seen a few cases with hepatocellular carcinoma over the past few years. Actually, one of them had finished chemotherapy and had co-infection with Hep B and C, and he was 11 years old. And several others were diagnosed by accident at the age of 12 or 13 and could not be saved, and it was a perinatally transmitted hepatitis B. So it is not uncommon, however, it can be prevented. Spontaneous clearance increases with age, and I'm going to show some recent data. 4 to 10% annual antigen antibody seroconversion, less than 2% of less than 3 years, and up to 70% by the end of adolescence. 0 to 1% annual S antigen to antibody seroconversion rate. Then the inability to clear the virus is common in those who acquire the infection perinatally. So it's really important that we focus on perinatal prophylaxis. And given the fact that only 34% of countries are giving the birth dose and almost none have a perinatal prophylaxis policy, it is really important that on a global front, we raise awareness and increase the perinatal prophylaxis guidelines, improve them. These are data that have recently been published from Toronto, looking at a 25 years experience in children with chronic hepatitis B. 252 were included, 59% were infected through their mothers, and 77% were Asian, 33 received interferon. The E seroconversion rate was 41.7% over this period of follow-up, and almost 50% achieved inactive chronic infection by the age of 19 years. Being non-Asian, age of diagnosis less than 3 years, and ALT more than 40 were associated with a higher rate of E seroconversion. But we know that the concepts of immune tolerance have changed, and the balance now is tipping towards looking at inflammation, integrated DNA, and I think this is really important for children because most of the children we're seeing are immune tolerant children, and most of them have very high viremias and normal ALTs. And even the definition of normal ALT is not very clear because we define ALT as up to 30 or up to 40, but we don't really know if this is the normal ALT, and we need to decrease the bar for children. So is liver biopsy still indicated in those cases? Some cases, yes, indeed. I'm going to show this case, 5-year-old child with chronic hepatitis B, and he had an ALT, AST elevation for more than 6 months. He was eligible, very high viremia, and it was a big question at that time. We used to biopsy all patients at that time, so to treat or not to treat this child. He had a liver biopsy, minimal inflammation, mild portal fibrosis, and he had a positive S antigen in a very small percentage, and core antigen positivity in less than 1%. And actually, the pathologist told me, this child is going to clear the virus. So I waited longer, and he seroconverted E antibody positive, and he's been E antibody positive for the past 7 years and DNA negative. So that's why we need to discuss immune tolerant in a different way, and I think we need to come back to consideration of liver biopsy in some cases who might be considered for treatment. So we are often bombarded with those questions every single time the patient comes. When am I going to receive the treatment? Are you leaving my child with a high viral load? He can transmit the infection to others. Is it safe for his liver? And what are the chances of transmission? And of course, above all, we forget about the stigma and discrimination. Children do not divulge that they're infected with either Hep B or Hep C in schools because they're discriminated against. This is really important. Those are the treatment recommendations for children. ALT elevation more than 1.3 times upper normal limit, at least 6 months, with HBV DNA elevations, level very high during childhood, more than 10 to the 6. And if the level is low, we usually wait. They might clear the virus. Interferon has been approved for children above the age of 1, and I think interferon is the best option. It's a finite treatment, although it has terrible side effects and it might affect the growth of children. We have now entecavir that's been approved for children above the age of 2 years. We have tenofovir approved for children above the age of 12 years. Duration of interferon treatment is usually 24 weeks, and the antiviral treatments have been studied for a long time. I have children who have been on treatment for the past 19 years. E-antigen seroconversion, like adults exactly, is being used as the marker, and we wait for consolidation 12 months, and then we follow up later every 3 months. So we need to control hepatitis B and C in children. I think I made my case. We need 2 strategies. First, prevention. And prevention as prevention, strengthening surveillance to detect viral transmission. We're not doing this. Promoting infection control practices, particularly in low-middle income countries, improving blood safety, eliminating transmission through universal hepatitis B birth dose implementation. We're still not doing this. Prevention of mother-to-child transmission by antiviral therapy, educating providers and raising awareness, and indeed research agenda. And if you look in the literature, you'll find that the research in children occupies less than 1% of the adult population. So I think we need to improve research in children. So what about treatment? Treatment as prevention, definitely for Hep C, because it's cure. Viral suppression for Hep B. Prevention of progression of liver disease, prevention of neurocognitive dysfunction that we're not considering, particularly in Hep C patients, prevention of stigma and discrimination, prevention of reactivation in the immune-compromised population, prevention of transmission to other populations, and prevention of mother-to-child transmission. We have lots of drugs now that are approved, but they're not accessible. They're accessible in very few countries. Entecavir for children more than 2 years, the syrup is not available almost anywhere. Tenofovir for children above the age of 12 years, available in some countries, not in others. HCV, of course, we had breaking news this year, 7th of April 2017, FDA approved soft-lead for children, or soft-riba for children with genotypes 2 and 3, for children 12 years and more than and above, and more than 35 kilograms. Also, EMA approved that last June, and there are trials in the smaller population groups. What about B? B, most of the trials are extrapolated from the HIV trials, so there are some TAF trials being done in children and adolescents. And there is a TAF trial also, recent for adolescents. And this has been the phase 3 efficacy trial for entecavir in pediatric patients. And there is a recent study also, just finished this study with entecavir plus pegylated interferon for the immune-tolerant children, but I heard from some of my colleagues that the results were not great. What about the ongoing pediatric trials? There are several ongoing pediatric trials. However, I'm not sure about how far they're going to go and as far as registration is concerned. Because companies get a waiver when they submit a pediatric investigational plan, and they extend their patency However, the production is costly, particularly for the lower age groups. And I think they need strong evidence to be able to spend some money on production and dedication of a production line for the smaller age groups and for the smaller doses of the drugs. So this is a big issue. I don't know if those drugs are going to go far. We have one registered drug. The other drug that has a high safety, soft-lead, has high safety, 6 to 12. However, we don't know when it's going to be registered. Those are the ongoing trials in my country. Actually, I'm conducting several trials with the generic drugs as well. I have a very nice trial with Gilead for children undergoing chemotherapy with reactivation of hepatitis C, and hopefully we'll be able to present the preliminary results next EASL for soft lead in adolescents and children, and the results are marvelous. We're doing also some studies with the soft DAC, and we're using the generic drugs because this is the only way to use a pan-genotypic drug and a cheap drug, and this also can reflect on other countries. And we also have a trial, a pharmacokinetic trial for the soft ravidesivir, the new NS5A. So those are some of our trials. The soft DAC presented last EASL. We had 100% in cirrhotics and non-cirrhotics plus minus riba. And we have also other studies extending with NS5A-based DAA therapy. In 37 patients, now they are 50, and we have almost 100%. Only one patient relapsed recently. There is also a study from one of my colleagues just published looking at 8 weeks of soft DAC and looking at a marker of 2 weeks of rapid virological response after 2 weeks. Those who were negative continued for 8 weeks, and those who were positive continued for 12 weeks. And it had also 100% for the 10 patients. On the right side, there was also another study from a team from my university, also presented last ASLD, looking at soft DAC even at a younger age, but I think they had to divide the tablets, and that's why they didn't give great results. I'm not sure that was the right dose for the smaller age groups. And this is the study that we're publishing now for 150 patients with soft lead, and these are generic drugs. We had 98% sustained virological response with minimal side effects. So what about the other studies in the literature? Now we have the 6 to 12, very high efficacy and safety. Only one child relapsed in the group that has been tested. And this was a PK study and then extended to a formal trial. And we hope that it gets registration soon. And this dose is different because it's a 200 milligram sofosbuvir, and it is a 45 milligram ledipasvir in a fixed dose combination. And I think they are working also on the smaller age groups, 3 to 6 now, with the granules. What about prevention of mother-to-child transmission of hepatitis B and C? Of course, we have data to prove that hepatitis B can also be transmitted in the second trimester, not necessarily in the third trimester, and it's been found in the trophoblasts. And also for Hep C, similarly, they found the same quasi-species in second trimester as those in the baby, so they hypothesized that can also be transmitted in the second trimester. However, the majority are being transmitted in the third trimester, and it's been hypothesized as well that it might lead to some of the complications during pregnancy and for the baby. We've observed in Egypt, because of the high burden of hepatitis C, cholestatic liver disease in pregnant women who are Hep C infected. And we've seen that a lot, and we're conducting some studies now to look at this more carefully. And we're actually doing a study with the University College in London, evaluating the mother-to-child transmission and cutoff values for the viral load for transmission and the possibility of giving mothers treatment to prevent transmission completely. So we do know that there is immune prophylaxis. We do know that there is antiviral therapy that's available. However, the last WHO guidelines in 2015 could not find clear evidence to show that we can recommend an antiviral therapy for mothers who are infected with hepatitis B with high viremia. But evidence was created later in 2017. Lots of studies have been published with systematic reviews and providing clear evidence that we can use the antiviral therapy in mothers who are infected with high viremia. What about prevention of reactivation in the immune-suppressed population? I've been using lamivudine since 1998, and on the right side we can see the lamivudine, the earlier study with lamivudine with JSK. We looked at prevention of reactivation in children, and none of the children who received prophylactically lamivudine or later on preemptively, also bone marrow transplant recipients were included, experienced reactivation of hepatitis B. Before that period, I saw a lot of fulminant hepatitis and a lot of deaths from hepatitis B, and those are the biopsies showing clearly also improvement before and after treatment. On the left side, we can see the biopsy was helpful at some point in looking before the FibroScan and looking at how much they are being affected by multiple reactivations during chemo. Hep B patient on top, 2 years old, who had a fibrosis stage of 3/6. In the bottom, we have a child who have 10 years old, had leukemia also with a fibrosis of 3/6, had Hep C. And now we're doing the chemotherapy prevention of reactivation with the soft lead, and I think it's working wonderfully well. We have a huge cohort who's infected. But again, it's not only about reactivation or prevention of mother-to-child transmission. We do see sometimes extrahepatic manifestations of hepatitis C. The one on the left side had necrolytic acral erythema, and this, I've seen her first time when she was 12 years old. She received interferon, cleared the skin disease, but she decompensated within 3 to 4 years later, and she needed a liver transplant. She had a liver transplant in China. She was lucky to have a donor who supported her fully, funded her travel, and she was transplanted in China, but she received an organ that has occult hepatitis B, and she had a Hep B reactivation later on. She received lamivudine, and later on she remained with hepatitis C with no treatment for 7 years until the DAAs were introduced. And finally, now she is cured of Hep C with DAAs. She's married, she graduated, and this is her baby on the right side. He's 3 months old. On the right side, there's another case with very rare encounter in children, which is lichen planus, skin disease, very aggressive. 11 years old child also had the perinatal transmission of hepatitis C. Both parents had Hep C, and he had a fibrosis, advanced fibrosis on FibroScan. And after starting the DAAs, 2 weeks later, this is his skin lesion. I'm waiting for his end of treatment response. I'm looking forwards to get some more photos for at the end of treatment. And also, it's about quality of life. I have children who had severe bone aches, who cleared their bone aches after being treated for hepatitis C. And I have children who are, after treatment, report being much more active, back to sports, better performance in school. We're not looking at this part. Adult hepatologists always think that we do not need to treat children. They can wait until they're 18, of course, to stay in the business for a very long time because they're going to be out of the business for Hep C. But I believe that we should treat as early as possible because we have to give those children their lives back. They are not living their lives properly. And I think it's very important that we give their lives back. This is another challenging case. She had a lot of comorbidities, hepatitis C, secondary autoimmune hepatitis. She had iron overload. She was cured of neuroblastoma, solid tumor in children. And she had a fibrosis of F3. We started by chelating her first. She received a chelation therapy, iron overload went down, serum ferritin to less than 1,000, and then she started for the autoimmune hepatitis to be treated with steroids and then azathioprine for a few years until we had the DAAs. She was by then 14 years old, and I gave her soft DAC, and after soft DAC, her FibroScan, latest FibroScan, she achieved SVR, and her latest FibroScan was F0, F1. She had a 5.8 kilopascal. So this is very, very successful also. In Egypt, the government is not yet supporting, although they've supported more than 1.4 million treatments for hepatitis C. For adults, they're not yet supporting treatment of children, but I've been treating children through donations and funds collected from different organizations for the past 25 years. And this is my civil society. Actually, I'm the Secretary General of this society. It's called the Egyptian Liver Care Society. We're supporting liver transplant patients by more than half their cost of the liver transplantation. And we support children also who need treatment for hepatitis C. We supported 1,000 children in different centers, and we created different centers all over the country. And we supported more than 1,000 children's treatment with PEG, interferon, and riba. The last phase had a better response rate of almost 70% because we selected the IL-28B CC genotype patients. And now we are going to support the treatment of 1,000 patients with the new DAAs. So again, I'll go back to the same question, why treat hepatitis B and C in children? So again, from the clinical perspective, there is a cost advantage. And if we look at the smaller children, it's a weight-based dosing, but the pharmaceutical companies would disagree because that needs a special production line and they have to produce special formulations for children. So that's disagreement. A relative absence of comorbidities in most of the children, benefits of eradicating and suppressing the virus before the high-risk behavior, and we've seen that high-risk behavior is associated with high risk of transmission, better tolerance to medication and excellent compliance with treatment, and we need to treat children with comorbidities definitely because of the relentless progression of liver disease. From treatment perspective, children are better candidates. We need to avoid disease progression, remove social stigma, school performance and fatigue should be improved. And we should remember that curing one patient, that's before the lowest cost that we have. This analysis we've done before, we had the drugs now at 1/1,000 of its cost in the US. We have a full course of treatment in Egypt now for $70 to $80, 12 weeks treatment. So I think it's the cheapest globally. But before that, we had it at a higher price, but we still could see from this cost-effective analysis study that curing a patient saves with $10,000 for the next 15 years, and preventing a case would save $20,000 for the next 40 years. And we should remember that we're improving the quality of life. What are the challenges and gaps? Of course, research gaps, many research gaps. Prevention of mother-to-child transmission, we're not yet screening pregnant women, except in on a limited scale. We need to treat women as early as possible in childbearing age. We don't have point-of-care testing and diagnostic tests. We had some studies with the OraQuick, but it's still very expensive. For children, early treatment of children with comorbidities. Pediatric clinical trials and registration is always delayed, although we have a much safer drugs now. Stigma and discrimination. The economics of manufacturing the pediatric formulations. Access in low and low-middle income countries to prevention and treatment. We need to engage families in service delivery programs, particularly for adolescents. This is very, very important. And we need to expand testing for women and their children. So those are critical needs. We need a database, a global database, and database networking. I think we started doing something like this with the PentaHip network from Europe. And we need to have some finance and development models, financing the R&D and production. And we need to eradicate Hep C before adolescence, before the high-risk behavior. That's a critical need. We need to prioritize DAA lists, and we need to partner with the generic companies to start and conduct more trial with the cheaper drugs to be able to expand access in the low-income countries. Of course, we need a shorter duration. However, with whatever we have right now, it's much better than interferon. We should remember that hepatitis C is curable, and we need more clinical trials for hepatitis B and the immune tolerant. We need to find a solution for those reservoirs of infection who are transmitting infections to others. Those are other service delivery issues, particularly in adolescence. Age of consent. We always have legal policies. We need, of course, when you conduct clinical trials, we don't get only a consent from the legal guardian, but also an assent from the adolescent himself. Disclosure and stigma, and this is a huge problem. Access to adolescents to service delivery places. Countries like the US and other countries who have injecting drug users who are mixed within the community should be engaged within service delivery very early before they get into other drugs. And I think that should be made very clear. And I think the last paper published in Journal of Pediatrics looking at the substance abuse in the US should highlight this issue and should create more service deliveries for adolescents. Cultural, of course, and social barriers for adolescents, that's one of the issues. I would like to end by this slide looking at some of the successes we've achieved in 2017. We've had huge media attention this year. I wrote a media press during the Global Summit in Brazil with WHO, and that was on BBC News, and we had it also in Africa, a very nice article in Africa. We had a full chapter this time in the guidelines of hepatitis C. I've been fighting for years. And finally, I have a full chapter in the guidelines of WHO. This year will be published next April for children in the updated guidelines. We're working through the PENTA network now, PENTA Hep network. We're working with the global accelerator of WHO with companies for pediatric formulation production. And we had a meeting last December, and we're moving forwards. We had a side meeting allocated at the Global Summit for the first time for a full hour that was fully mine for pediatrics. I'm doing a couple of global projects for Easy Liver Foundation now. And I think the biggest success is that we're curing more and more children. We're curing a lot of children with hepatitis C now. And I think that's the great success. And more meetings are considering children, Hep DART, the International Viral Hepatitis meeting, and also I had a newsletter with the EASL Foundation newsletter website, and I think that's more attention to children, and that's really fantastic. So with the major gaps in viral hepatitis care, and if we want to eliminate hepatitis by 2030, and this is my message, this is my only message, this is the summary of what I said, we need to prioritize children, adolescents, women in childbearing age within the cascade of viral hepatitis care and treatment. I would like to acknowledge the efforts of all my colleagues at the National Committee for Control of Viral Hepatitis since 2006, the Egyptian Liver Care Society, my NGO, the National Cancer Institute, where I'm a consultant and also consultant at the 57357 Children's Cancer Hospital, my faculty, the Clinical Research Institute, and of course, without the support of my patients and their families, I wouldn't have been able to be here today. And I would like also to acknowledge the support of all funding organizations and donors who have been supporting treatment of children for many, many years. Thank you again. That's my point.